Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Ridzwan bin Jamislan, nama matrix 050274. And for today, I will be presenting my case studies while I was doing my intern at Klinik Kesihatan Kuala Berang. So for both of my case studies, I will be using this table of content, which consists of 1. Introduction, 2. Nutritional assessment and intervention using the SOAP assessment, 3. Discussion, and 4th, conclusion. For the first case study, which is childhood obesity, the introduction for the patient, patient's name, patient X, the age, sex, race, which is 3 years, 1 month, female and Malay. For the living condition, she is second out of the 2 child and in a B40 family. The medical diagnosis was she was obesity with weight 23 kilograms, height 98 centimeters, and BMI 23.7. For the medical history, there is no medical history, and the reason of referral is because of overweight gain. So for the first nutritional assessment and intervention, subjective, the weight is 23 kilograms, height 98 centimeters, and body mass index or BMI 23.7. As for the objective, the actual weight at 3 years and 1 month is, we want it to be 17.5 kilograms, and using the Schofield formula, the estimated energy requirement is 920 kilocalories per day. So recommendation for energy requirement is 1210 according to RNI in 2017. So for the energy intake recommended for this patient X is 1100 kilocalories per day. As for the assessment of patient X, for breakfast, she had 2 scoops of white rice plus 1 fried chicken, 1 nugget and 6 ounces of milk. For lunch, 2 scoops of white rice with 1 fried chicken and 6 ounces of milk. In the afternoon tea, 5 pieces of chicken nugget and hot tea, while for dinner, 2 scoops of white rice plus 1 fried chicken, 1 cup of Milo and 6 ounces of milk. All of this contributes to the total of 2,142 kilocalories per day, which is a large amount. So as for the plan for the nutritional assessment and intervention, the number 1, achieve a normal Z-score for weight and BMI for age. Second, achieve a proper meal pattern and make it a regular. Third, eat 5 meals a day with 3 meals and no more than 2 snacks. Fourth, have adequate breakfast. Fifth, avoid eating between meals. Sixth, avoid high energy and low nutrient density foods. 7. Increase intake of fruit, vegetables, and fiber-rich cereals. And 8. Limit portions. As for the recommended menu planning, we can see right here the macronutrient, carbohydrate, protein, and fat. For the percentage, 60 for carbohydrate, 15 for protein, and 25 for fat. So all of this contributes to 6 exchanges of carbohydrate, 2 exchanges of protein, and 3 exchanges of fat. This is the exchange table done using the calculated exchange from the previous slide. So this is the menu planning for weekday 1. We can see that the white rice has been reduced from 2 scoops to 1 scoop, and this is to ensure that the calories intake is not that many from her previous intake. This is the menu planning for weekday 2 for patient X. And this is for the menu planning for weekend for patient X. As for the discussion, children under 5 years are classified as obese when weight for height is greater than 2 standard deviations above the WHO Child Growth Standards median, and obesity is weight for height greater than 3 standard deviations above the WHO Child Growth Standards median, according to Kim in 2016. In this case study, patient X was diagnosed with childhood obesity at 3 years old. Her Z-score of the weight for age is greater than +2 and her BMI for age is greater than +3. The reading of her BMI was 23.7 and she was classified as overweight. Overconsumption of food and milk intake caused patient X obesity clearly, and high consumption of fried chicken also contributed to unhealthy meal for patient X and thus affects her eating diet. Next, high carbohydrate intake is also one of the factors that contributes toward overweight. Excessive carbohydrate intake can coercion one's body with infiltration of monocytes into adipose tissue, associated with obesity that can result in inflammation and metabolic problems, according to Mook et al. In 2021. Milk consumption should also be reduced to 2 servings per day, as it is enough for daily consumption and over-consuming it will just add more calories into the diet. Fruits and vegetables needs to be implemented in patient X's diet, and her caregivers or parents needs to be more responsible into patient X's diet as it can affect her in the long run. In conclusion, patient X was categorized as an overweight child. The dietary management plan includes giving various carbohydrates in her main meal and decreasing the amount of milk in her diet. Protein from different sources is also included in the plan, such as fish. Other than that, many fruits high in vitamins are also included in the plan to increase the immune system of her body. Now we move on to the next case study, which is anemia in pregnancy. So as for the introduction, the patient's name is Mrs. Y. Her age is 35 years old, a female and a Malay. The living condition, she is married, a housewife, and has secondary education level, which is SPM. For the medical diagnosis, she had anemia with her hemoglobin level at 10.10 in week 31 and 10.01 at week 35 of pregnancy. As for the medical history, she has a history of iron deficiency anemia for her first child, and this is due to her second child. As for the reason of referral, high anemia in pregnancy. For the nutritional assessment and intervention subjective, the hemoglobin level for GM per DL in week 8, 12, 16, 23, 25 and 29 respectively. Her level was 12.4, 12.1, 12, 11.8, 11.4, 11.1 respectively, which are normal. As for the hemoglobin level in week 31, 33 and 35, they were 10.10, 10.5 and 10.1 respectively, which are in the mild anemia category. As for the blood pressure, it is 115 over 72, which is normal. So the objective is to achieve normal hemoglobin level, which is over than 11 gm per dl. And the second one is to increase intake of heme and non-heme iron-based foods in her dietary plan. As for the assessment, a food checklist of heme and non-heme iron-based food was run by our nutritionist and her. So as we can see, that there are 4 types of food, which are red meat, kerang, chicken liver and nuts, with the intake only 1 over 7 for the 3 of the first, and nuts being none at all. And this indicates that it is a very low intake by the patient. As for the vegetables and fruits, she only took 3 out of 7 of vegetables and 2 out of 7 fruits per week, and this too also indicates that it is a very low intake for both of the groups. As for the plan for Mrs. Y, the first one is to increase intake of heme and non-heme iron-based foods. The second one, increase intake from animal-based food compared to plant-based food. Third, incorporate drinks, juices, fruits and vegetables with high vitamin C content to enhance iron absorption, as well as avoid caffeinated foods such as chocolate, coffee and tea from main meal to nullify iron absorption reduction. Over here we can see the plan for the menu planning. For the percentage of carbohydrate, protein and fat, carbohydrate gets 60%, protein gets 20% and fat gets 20%. As for the exchange, the carbohydrate has 11 exchanges, protein has 8 exchanges and fat has 1 exchange. So over here we can see the exchange table for Mrs. Y menu planning. So based on the menu planning exchanges, this is the menu planning for weekday 1 for Mrs. Y. This is the continuation for weekday 1 for Mrs. Y. Menu planning for weekday 2 for Mrs. Y. And the continuation of menu planning weekday 2 for Mrs. Y. And this is menu planning for weekend. As you can see from weekday 1, weekday 2, and the weekend, there are more fruit juices, vegetables, basically heme and non-heme iron-based foods incorporated into Mrs. Y menu. This is to help the iron absorption in her body. As for the discussion, anemia is defined as a reduction in an absolute number of circulating red blood cells, or RBCs, indirectly measured by a reduction in hemoglobin, which is Hb concentration, hematocrit or RBC count, based on Carlo et al. 2015. WHO stated Hb amount lower than 11 g per dl is considered as anemia, but it varies during trimesters for pregnant mothers, such as less than 11 g per dl in the first, less than 10.5 g per dl in second, and less than 11 g per dl in the third trimesters, according to WHO in 2014. According to Mrs. Y food checklist, it is clearly seen that she has not taken enough iron-rich foods, and not taking iron tablets does only add salt to the wound, as she has not have enough iron intake. A study stated that iron supplementation is important to prevent IDA, iron deficiency anemia, especially in pregnant women, based by Folifak et al. In 2019. Next, caffeinated drinks which reduces iron absorption were also consumed by Mrs. Y, and hence she was suggested to reduce the intake. Beverages such as fruit juice contains high amount of vitamin C and is the only dietary component demonstrated to aid non-heme iron absorption in humans, according to Lee et al. In 2020. Heme iron, which are obtained from animal, are more effective and account for 10% or more of our total absorbed iron, based on Ames et al. In 2021, and is advised to be taken more than non-heme iron foods. As a conclusion, Mrs. Y had been diagnosed with iron deficiency anemia (IDA) based on hemoglobin reading below level 11 gram per dl on third trimester. This problem can be overcome with better dietary management that includes high amount of iron-rich foods, especially ones rich in heme iron as well as vitamin C for iron absorption, and reducing caffeinated beverages intake. These are some of the references that were used for this case study. That's all from me. Thank you very much.